Good evening, everyone. I'm Dr. Ken Piper, kind of your moderator for this evening. This is the third of our virtual medical town hall adventures. Many of you joined us in the auditorium over the past few years, and we're pleased to be able to continue this program in the face of the joys and sorrows that we've all dealt with this past year. Tonight we're going to focus on arthritis, and we have Dr. Ryan Gursky, who is the lead surgeon for the St. Francis Joint Replacement Center. When we talk about arthritis, we're talking about bones and joints and ligaments and tendons, and we'd like you to send in your questions, and please use the chat. You can put a few words in, you can put in a little sentence if you'd like, and I'll be looking at those as Dr. Gursky's talking and afterwards, and we'll address your questions and your concerns in every way we can. St. Francis is pleased to continue these community education programs. We welcome you. Thank you for visiting, and I'll turn it over to Dr. Ryan Gursky.
Thank you, Dr. Piper. I am Dr. Ryan Gursky. I am the lead physician in charge of the St. Francis Joint Replacement Center, board-certified orthopedic surgeon, really specializing and honing my expertise on the area of knee and hip replacements. Today's lecture is going to be focusing on hip arthritis, the evolution of, as well as the treatment of, and alternatives associated with arthritis of the hips. To just cover the quick agenda, again, we're going to talk about how the hip works, why it hurts. We're going to talk about whether hip arthritis is preventable. We're going to talk about some of the options associated with hip arthritis, as well as some of those surgical options available for total hip arthroplasty. Conclusion, questions, certainly at any time, Dr. Piper is available to take in questions and can relay that to me at any point in time. If something comes up and you want to ask, feel free. This is my first time doing this in a virtual setting, so it's a little unusual for me, so bear with me if there's any complications with that. So to begin, how does the hip work? We have to understand how things work by understanding their anatomy. The anatomy of the hip is a ball and socket joint. In that, the ball, otherwise known as the femoral head, is here, and it sits inside of the socket, which we would commonly call acetabulum in the orthopedic world, but for us, we call this the ball and the socket joint. That socket is actually a fusion of the three bones of the pelvis that form the pelvic girdle. What is arthritis of the hip? Well, again, to understand pathology, we have to understand normal. So the normal anatomy of the hip on this picture does show us the normal ball and socket joint. It's basically the end of each bone is covered with a cartilage, an articular cartilage structure. This acts as a cushion. This is our shock absorber inside the joints. So all bones at the end of the joint space have a cartilaginous articular cartilage coverage. This is what allows us to weight bear, function, move without pain and discomfort. A diseased hip, picture next to it, shows the changes. This is basically a degenerative osteoarthritic process that we're seeing on the other picture that's showing wear and tear, deterioration of that cartilage cushion, which is the first stage of osteoarthritis, followed by then bone changes, bone formation, what we call osteophytes. Other people just commonly call them bone spurs, to the point where we develop what most people have heard of as bone-on-bone changes. That is where we've lost all of our cartilage and now bone ends are actually contacting each other. This is going to create soreness, swelling, loss of mobility, and all the symptoms associated with it. If we look at it from a radiographic standpoint, what we're going to see here on picture number one with a normal hip is normal ball and socket anatomy. We're looking at the spherical nature of the ball. We're looking to see if that matches the contour of the socket. And more importantly, we're looking for this space in between. The space in between on a radiograph, on an x-ray, is what is giving us the understanding of how much cartilage is present. So that space is not empty. That is actually the cartilaginous coverage that gives us our cushion. The more we have, the better. You can see on the right, or at least on my right, that the diseased arthritic hip looks quite different. It's always a fairly dramatic process. We see a loss of that articular cartilage height, and then the approximation of the bones. The bones start to contact each other. This particular image does show us a more advanced process of just probably a later stage arthritis, because we're actually seeing what we call subchondral cystic changes. So these little cysts inside the bone, these are actually weakening of that bone structure because of that bone contact. This starts to create what we call a collapse of the bone. When that bone collapses, we start to lose that spherical nature of that ball and socket joint. And again, we start to displace or move position, so that ball is no longer located within the socket. It has moved and displaced to the outside.
Dr. Gursky, before you go on, in a disease tip, could you show the audience where a hip fracture most likely occurs most frequently?
So, and I will probably just use this normal hip to kind of describe it because it gives me better anatomy. But again, and I'm hoping you can see my arrow on here. So I'm kind of circumscribing the femoral head or the ball. So the most common fracture that we see is what's going to be called a femoral neck fracture. So that is the portion just below the ball, and this is considered the femoral neck. The most common is going to be this area right below, right at that junction between the femoral neck and the femoral head. We also have a secondary fracture that's going to be located right here in this big bony prominence, and it's going to run, it's going to run diagonally across this area of bone, and we're going to call that an intertrochanteric fracture. That's going to be our second most common. Treated very differently, but those would be our two most common hip fractures. Back to arthritis. Arthritis is the second most common chronic condition in the U.S., only following sinusitis, most commonly occurring among the elderly. 20 to 30% of people over the age of 70 will suffer from osteoarthritis of the hip. And then arthritis affects over 32 million people in the U.S. Total cost somewhere around $82 billion per year when we look at hospitalization, drug costs, nursing home costs, treatment costs, as well as loss of productivity. So the next important slide then becomes how do I discern arthritis of the hip? There are multiple forms of arthritis of the hip. Specifically, when we talk about arthritis, most commonly we're going to talk about this first one, osteoarthritis. This is commonly going to be our degenerative wear and tear arthritic change, and by far the most common that we see. The second, and then we're going to look at post-traumatic. Post-traumatic is going to follow any traumatic injury. So somebody that has a car accident, a fall from a height, a previous femoral neck fracture, intertrochanteric fracture, hip dislocations, as a child, as a young adult, they are much more prone to developing post-traumatic arthritic changes, mainly because of the change in anatomy and because of the change of the forces associated with that joint. Next is inflammatory. Inflammatory is another big arthritic contributor, and this is going to consist of a lot of those autoimmune, rheumatoid arthritis. We call them inflammatory arthropathies, but they're basically the body attacking that structure. Next is avascular necrosis. This to me is probably one of the most up and coming diagnoses that we're seeing for the necessity for hip treatment and specifically hip replacement. We're seeing this occur at a much younger age. We're seeing this at our patients in their 20s, 30s, and 40s. Avascular necrosis is the process of loss of blood supply and death of the bone. So if we were to go back to that picture, what we would see with avascular necrosis is going to be the blood supply actually coming in from this area back here, across the femoral neck into the femoral head, gets kinked off. We lose that blood supply, and it really is about the 90% of the blood supply that femoral head needs to survive. When we lose that, we start to lose the integrity and the structural support of that femoral head, and it starts to collapse. Next, childhood hip diseases. These are going to consist of slipped capital femoral epiphysis. This is going to occur in young kids, usually somewhere between 8 and 12, and it's basically a growth plate issue during the adolescent age, and they actually lose some of the integrity of that growth plate, and they actually slip and they malform that ball in the ball and socket joint. Second is going to be hip dysplasia. Again, one that we're commonly seeing. In fact, the patients that I'm replacing hips in, sometimes even into their early 20s, are suffering from early hip dysplasia. That's a congenital developmental issue where the hip does not develop appropriately. If we look at how the hip develops, it really takes that femoral head to be positioned appropriately within the socket and the developing socket. If it is not, it never develops. So those patients don't actually ever develop a socket. And then over time, usually in their 20s and 30s, they start to develop a lot of secondary arthritic changes, oftentimes necessitating surgical intervention. And then many more. There are many more than that. That's just the crux of what we see. The next question is arthritis of the hip preventable? And the conventional answer will always be no. And I think for the most part, when we look at the major contributing factors of degenerative arthritis, we're looking at genetics, quality of your cartilage, the wear and tear of life, and then those little minor injuries that occur throughout your life that create what we call little micro traumas, and lead up and end up with that arthritic process progressing. We've always kind of encouraged in that process to remain active, maintain flexibility, but that it's inevitable, it's going to progress. Now, we will say in some instances, maybe sometimes it is preventable. In that particular instance, we're looking at what we call femoral acetabular impingement, FAI. Femoral acetabular impingement is a relatively new diagnosis in the last 10 to 15 years and really has to do with hip anatomy. What it deals with is a mismatch between the roundness of that ball and socket joint. Oftentimes it's associated with some form of a congenital abnormality or childhood injury. It creates what we call an abnormal cam effect. So when we're looking at the movement of that ball and socket joint, it's just not fluid, and there's impingement occurring between the bones. This often leads to tearing, injuring of the soft tissue, and then further into degenerative changes of the hip. This is an example of some of the femoral acetabular impingement structural changes. If we look at that top on my side, the left picture, this would be our normal anatomy. Again, ball and socket joint with nice congruent formation. Over here, this would be a cam change where we've actually got a buildup on that femoral neck. That femoral neck in the front portion has been built up because of bone abnormality, abnormal growth, and does not allow for that motion, and we develop what we call impingement. The next is a pincer effect where the acetabulum or the socket portion overdevelops bone and does not allow for enough movement before we get impingement here in that area. Next is going to be a mixed. This is going to usually create a significant amount of lack of mobility. We're going to see a strong change in their flexibility with this kind of anatomical change. Our concern is that we end up developing what I call, or what they say is labral tearing. Labrum is this band of tissue. It surrounds the socket or the acetabulum. I always describe it to my patients as an extra suction cup. It gives us a little more support, a little more stability in that socket joint. And when we have that impingement, we develop tears. And when we develop tears, that develops into issues with stabilization of the soft tissue on the surfaces of that socket. They do allow for progression of arthritis, typically at a much earlier age. What are the symptoms? We typically look at patients, usually in their 20s, 30s, early 40s, with onset of groin pain, difficulty with sitting, difficulty with deep flexion of the hip or squatting. They will get a clicking or popping sound, especially when you get into something that creates a twisting or torsion motion on that hip. such as a golf swing. The pain is typically progressive, so it starts out as mild, controllable, and then progressively worsens. And the pain is not always constant. It's usually intermittent and oftentimes activity dependent. Treatment, we look at things like hip arthroscopy. Again, something that probably followed the evolution of this particular diagnosis of femoral acetabular impingement. Hip arthroscopy developed. Allows us to enter and perform surgery in the hip through a camera. Through microscopic and small incisions, we can place a camera and perform work to repair labrum, to debride soft tissue tears, to try to debride bone and reduce impingement in that situation. Other surgeries for this are going to be open, whether it's mini open, what we call decompressions, hip socket reorientations, a much more aggressive surgery, and physical therapy, as a side note, usually is not extremely helpful for femoral acetabular impingement. These treatments are effective at relieving pain. They may even slow down or prevent the progression of cartilage damage and the development of arthritis in many of the cases. The majority of times, arthritic progression in the hip, however, is not preventable. So let's go into hip arthritis and symptoms. If we look at it, groin pain is going to be the number one symptom. This is important to differentiate the cause of the hip pain. The hip joint itself is located in the groin. There are a lot of other structures associated with it, but the most common presenting symptom is going to be it hurts in my groin, in the front of my hip, and radiates towards my buttocks and then down to my knee. Loss of motion. I can no longer bend over and tie my shoe. I can no longer bring my leg up and cross my leg. Those are signs even early to the mid-range where we're actually developing that arthritic change. Gait abnormalities or limps, stiffness in the hip, pain with weight bearing is going to be a common sign, and limitations to daily tasks. In severe cases, we got to see actual changes in leg lengths, so you'll see discrepancies in those leg lengths that will contribute to that limp as well. What are our treatment options? If we look at the non-operative side of it, the first thing we're going to talk about is activity modifications. It's like my mom said, if it hurts, don't do it. We can modify our activity. So if somebody says, hey, when I run, my hip kills me, but I can walk and I can bike and I can swim and I'm perfectly fine, then we can modify life. We can change the way we do our activities. Obviously, the hip is a weight-bearing joint. When we look at weight loss, it will always positively affect the weight-bearing joint. I can't tell you how many patients I've had, even in the surgical setting, when attempting to prepare them for surgery. We work aggressively sometimes on losing weight, preparing for a surgery, that they will get through that process, they will lose the weight, and they will say, oh my gosh, my hip doesn't hurt anymore, or my knee doesn't really hurt me much. I can tolerate it now. So a very big factor in it is going to be weight loss. Use of a walking device or supportive device, whether in cane or walker. These are instances where I tell people, look, if this is a matter of you having stability issues with the potential of a fall, we are much better off utilizing something to support ourselves. So it can help take pressure off and it can help alleviate some of the symptoms. Physical therapy. Physical therapy is a great conservative modality. It allows us to not just work on strength, which is going to be our major focus when we look at taking pressure off of the joint, but also maintaining flexibility and mobility. Medications, we can start with over-the-counter, non-steroidal anti-inflammatories. These are going to be your Aleve, your Motrins, your ibuprofens. Those are our typical starting point for oral anti-inflammatories. They obviously come with the price of having some potential adverse effects, so we have to be very cognizant of those that can and cannot take those medicines and for how long. COX-2 inhibitor is another form of a non-steroidal, but goes into the prescription strength. These are going to be your Celebrex, Mobix, the meloxicams of the world. Those are our prescribed stronger non-steroidals. Nutritional supplements, injections, whether it be corticosteroids, viscoelastic supplementation, or stem cells. Those are all fitting into that non-operative treatment category. But there is truly only one cure for arthritis of the hip. And this is the picture of that. It is going to be hip replacement. So I have a very common phrase or statement that I make to patients. That is, we have two choices when it comes to treatment of hip arthritis. We can live and work in that Band-Aid world of trying to relieve symptoms, or we can get into the world of fixing my problem and changing the anatomy. So truly, hip replacement is the only way to eradicate hip arthritis. Total hip replacement, implants are used to replace the damaged joint surface, both the femoral head and the acetabulum. Very important distinction. We're replacing both sides of the joint in that procedure. Used to help relieve pain and restore mobility. Can help to restore limb length differences and discrepancies. There are over 260,000 total hip replacements performed each year in the U.S. And those are from earlier, probably 2015, 2016 numbers. Goals of joint replacement surgery, specifically for the hip, relieve pain. That is number one. And that is what we try to harp on, is that is the major goal of that procedure. Two, restore function, mobility to the pre-arthritis level. And that's usually what I will get asked immediately is, can I do everything that I did before? Am I going to be like I was when I was 15, running around doing anything I wanted? And the answer is, you will not have arthritis in the hip, and you will relieve the arthritic pain, but I won't guarantee you the ability to return to the 15, 20-year-old status. But we do want to return to as functional level as we can, and I think that is truly the goal. Patient does not have a bionic hip, though. They can still create pain, and they can still injure structures around the hip. So they have to be aware that there are certain precautions and things that we need to be doing on a regular basis when it comes to a joint replacement. So what is a hip replacement? This picture again shows us the components of a hip replacement. Starts with, at the top, the shell labeled here is the new acetabulum or new socket. This is a metallic, usually titanium implant. This is fixated in to the hip and allowed for bone growth to occur into that implant. The next structure called the liner. This is the plastic portion that is placed right inside of that metal shell, and that gives us what we call our new bearing surface. So that is actually the portion where the joint meets and there is contact. This next is going to be the femoral head, here in that kind of pink, light pink color, because this particular one is a ceramic femoral head. But this is actually the new ball in that ball and socket joint. So our junction in the new hip joint is going to be this plastic liner with this ceramic femoral head. The ceramic femoral head is actually fixated to a metallic or titanium stem that is placed down inside of the thigh bone. That is our stabilizing point to placing that new femoral head. What is the technique of total hip replacement? Well, the first thing we do is we disarticulate that joint. We remove the femoral head, usually here just below the ball and the ball and socket joint. We fashion a new socket. So we use a reamer and we open up that original socket and we place our metal socket into place. That metal socket has a plastic liner that is locked into position. And then we address the femoral side by placing that femoral stem down inside of the bone. Once it's well seated, we place that ball on top of the new stem, and then we rearticulate the hip. That is how it's performed. Total joint replacement is one of the most commonly performed and successful operations in orthopedic, as defined by clinical outcomes and implant survivorship. Implant design has evolved dramatically over the years. Over here on this picture, you can see some of the different designs, some of the different techniques, some of the ways that we've changed the implant over the years, but they have definitely evolved dramatically. Surgical approach and technique as well have evolved significantly. What are our implant considerations? When we look at total hip, the first thing we're always looking at is bearing surfaces. And the improvements in technology change. We change our bearing surfaces. Those are the contact points and the movement points of that hip joint. The components have definitely become much more durable, a more viable option for younger patients because they are more durable. The most common thing we hear now, especially in the clinic when we talk about hip replacement, is are you going to use a metal on metal? That's the one that we're hearing about on TV. We're having a lot of issues with having recalls and changes in that bearing surface. And the reality is metal on metal is not even an option. It's not even available to be placed any longer. But those are the recalls that we've had more significantly in the U.S. So again, when we talk about contact points, bearing surfaces, we talk about three options in hip replacement. One is going to be metal on plastic, or what we call metal on polyethylene. That is our standard. That is our gold standard that we've always used. And then we've got ceramic on poly. This is probably really becoming the new gold standard because what we're learning is that ceramic on plastic or polyethylene has a much better wear rate. So that implant lasts longer and has much more durability to it. Ceramic on ceramic is an option. The downside early with ceramic on ceramic is going to be that it created a squeak. We actually had some noises that were created by that implant originally, and so it really turned a lot of people off. But if we look at our wear patterns, the durability of that implant, truly ceramic on ceramic probably has the best rate of survivorship, but it does have some definite setbacks. When should your patient consider a hip replacement? Really, if the arthritis has caused an unacceptable level of pain, decreased level of activity, ability to participate in activities, then that they consider essential. They have acceptable surgical comorbidities. There's good rehabilitative potential. This is probably key. There is no reason to go through a major surgery if we cannot rehab the surgery. And age is really less of an issue with current technology. As I was talking to Dr. Piper before this, I talked about the spread in age from which I performed a total hip, and it's all the way from 19 years old up to 96 years old. So chronologic age does not always play a factor in having that performed. What are the risks of total hip replacement? Number one is always going to be dislocation. We found this to be actually more true when it came to other approaches or particular approaches, but that will always be a major factor when we look at hip replacement. It is not what God gave you. It is not the natural hip. It does have the ability to be dislocated and sometimes requires certain restrictions following that surgery. Leg length discrepancies are a possibility, although with newer technology, whether it be computer-assisted, robotic surgeries, there's a lot less issue with leg length discrepancy. Infections are always going to be important when we talk anything surgical, especially in the world of implanted surgical implants. We don't want to develop infections around them, so we want to work hard to prevent them, but it is still a risk. DVT, PE, these are going to be deep venous thrombosis leading to potential for that clot going to the lung, or otherwise known as a pulmonary embolus. These are at risk with any lower extremity surgery, and nowadays it's really about the prophylactic treatment. It's the treatment of patients before any of these things occur that we're really focused on. So there's a lot of work done to make sure that we don't develop these problems. Intraoperative, perioperative fracturing, loosening of a component when it's not involved with infection, we just call it aseptic loosening, and then the further surgery potentially to revise components. Dislocation precautions, like I said, that is probably one of our major factors when we look at hip replacement, and so there are precautions. There are certain issues that we will have with leg position, leg location. Originally, it was really associated with what we call the posterior or backside approach. So the direction we came in really depended on the restrictions we put you in. So most people conventionally before 10 years ago would have gone through what we call the posterior approach, and it would have limited your ability to flex at the hip more than 90 degrees or cross your legs over for a significant amount of time post-operatively. Leg length discrepancies, recovery, they can all be dependent, again, like I said, on surgical approach and how we enter the hip. And so we look at the advantages and disadvantages of each one of those approaches, and then the surgeon preference and comfort with the approach. The first approach we'll talk about is that classic posterior approach. That is the one that was the gold standard, and still technically is the gold standard. And we have this standard versus minimally invasive. But you got to understand this is actually the incision that's made along the backside of the hip. It does have the highest dislocation risk, and it is probably the easiest from a surgical standpoint, though, for exposure and risk of surrounding structures. This is the one that the most restrictions come with because of that highest dislocation risk, although some will say that that minimally invasive side of it has lessened that risk somewhat. Lateral approach, this is going to be coming from the direct side of that hip. There is a much lower dislocation risk, and it is probably the most damaging to the surrounding muscles. This approach does require that we remove tendons from bone, and then we have to reattach them. So there's oftentimes a much longer recovery process and weakness associated with that leg in the postoperative period. The third is going to be the anterior approach. This direct anterior is going to come from the front of the hip. And you probably can't see me pointing, but it's actually in the front side of the hip, and it actually has our lowest dislocation rate. However, it is probably the most technically challenging from a surgical standpoint. We are addressing and we are having to deal with surrounding neurovascular structures, and it's important that we have a very good understanding of that approach. I threw in here superior approach. Superior approach is more of a new up-and-coming approach, and it really entails using intervals, again, planes between muscles where we don't have to detach, much like the anterior approach, but yet it does not sacrifice any of the side, what we call iliotibial band, to have to incise through. I don't really actually know anybody locally that uses a superior approach, but it is out there. Again, if we look at that posterior approach, we're looking at that traditional longer incision for the standard approach. Minimally invasive approach is going to be much smaller, anywhere from 4 inches to 12 inches on that approach. We developed to create less dislocation risk and to decrease pain. Currently, no proven benefit to smaller incision, though, other than cosmetic appearance. Lateral approach, there is a much lower dislocation rate than the traditional posterior. Again, it does require detachment of the portion of what we call the gluteal tendons. So here we can see that a lateral approach comes directly from the side, but we do have to remove tendons from bone to get to the capsule, and there's oftentimes a postoperative limp and some weakness. This is probably the approach, though, that's favored most in what we call hemiarthroplasty, or a partial hip replacement, especially following a hip fracture. Anterior total hip. This, again, is an incision made in the front of the hip. So now we can see that correlation between the three. If you've gone through a hip replacement and your incision is back here closer to your buttocks, you are a posterior approach. If it's here along that far outside portion of the hip, that's that lateral approach. And this small incision up here, C, is going to be our anterior or direct anterior approach. There's a natural interval for this approach on the anterior side that exists between muscles. Basically, it exists in front of the hip, and the surgery is performed through that interval, through the tensor fascia and sartorius. And the muscles and tendons are not cut during this procedure, but we develop planes between them. This typically equates to much less weakness postoperatively. Patients are supine. This actually is the particular table that we have to use. They can be performed on regular operating room tables, but there are specialty beds made for this particular approach. The incision is anywhere from 4 to 6 inches long in the front of that hip. And again, muscles and tendons are not detached. Rather, they're just retracted in their natural muscular plane. We do use intraoperative x-ray or fluoroscopy during that procedure to help with localization of the implants, so we can actually watch everything that's happening during that process. Benefits of that particular approach is that the dislocation rate is going to be less than 1%. I've performed a little over 1,500 of these in the last 4 years, I believe, and I think I've had one dislocation so far, and it was a very unusual maneuver that was done, so it was a very extenuating circumstance. So I have a real affinity for this particular approach because of the real lack of dislocation risk. I do not have to place patients on restrictions, so hip restrictions are really gone. I don't place them on any kind of precautions. The leg length's much more reliable because we are using intraoperative fluoroscopy. The recovery time is much faster. This is the approach I went to about 5 years ago, and this is why. When I got down to watching the patients in the recovery process, I have yet to see anybody that didn't walk into my office at 3 weeks without a walker or cane. And there's really less pain. The use of pain medicines is much less in that anterior approach than the traditional approaches. What risks are associated? Again, it's a much more challenging approach for the surgeon. We do have to encounter and we have to deal with what's called the lateral femoral cutaneous nerve. So like I said, there's a lot more neurovascular structures present in this approach. And this is particularly one, it gives us sensation to the outside of the thigh. It is only a sensory nerve, but it does have to be dealt with and it has to be retracted and protected during that procedure. Intraoperative fracture has always been a more common occurrence in the anterior approach, mainly because of the position and the particular way we have to manipulate the leg. But that risk has become much lower. And again, I don't know that I've actually ever had an intraoperative fracture on anybody. Difficult without surgical equipment. So again, the bed, instrumentation, it has to be special in this approach. So if we don't have that, this can be a very technically difficult surgery. Who are non-candidates? Severe deformity of the femur. So if there's a lot of malformed anatomy, then that approach can be very difficult and they may not be a good candidate. I can think off the top of my head, one patient, less on a bone deformity, but on a restricted range of motion. He actually was a patient with inflammatory arthropathy that was associated with ankylosing spondylitis, had a lot of inability to move. His joints were fusing and he just had no mobility to it. And he was not a candidate to undergo this procedure. Otherwise, healthy, young guy that could have done it, but he just had no mobility to that hip, so it would have been technically challenging. Bone loss, severe erosions of the acetabulum. I will say that I'm finding this to be less of a risk or less of a contraindication, and we have definitely pushed the envelope in that anterior approach. Morbid obesity. We'll call BMI greater than 40 is probably a cutoff for most people, and I think that's pretty reasonable, mainly because of a healing standpoint and then an approach and a positioning standpoint. It's very difficult when we get that body mass index, which is just a relationship between height and weight. When it gets above that 40 mark, it becomes very difficult to perform that surgery, and they are probably better off going through a different approach. History of previous hip replacement surgery, so what we would consider revision surgeries, going in and changing out implants. That used to be a pretty concrete contraindication to this anterior approach, and it probably still is if we look at patients that had a previous approach from the posterior side. It's probably favorable to go in on that approach. But in my hands, I've actually been able to convert over to that anterior approach often in a revision setting, and it has been very successful. 95% of patients are truly candidates for that anterior approach. This can usually be assessed pretty quickly, and the operating surgeon should be able to discern that quickly and explain that, the advantages of that fairly easily. And that's it. That is the end of the lecture.
Dr. Gursky, we have lots of great questions from our audience. A couple that are talking about time. You mentioned the technology of the mechanics, the ceramics and the sealers and things. How long does a total hip last?
How long does it last? Great question. In fact, a question that everybody that's getting ready to have a total hip should ask is, how long is this going to last? And the answer is, there's varying factors, but if we look at traditional studies, especially over the last probably 5 to 10 years, we're looking at these more durable products at somewhere around 20 years. So I tell my patients, we have a lot of data and information showing that survivorship is going to be about 90 to 92% at 20 years. However, there are extenuating circumstances. There are issues sometimes with whether it be high-impact activities, patients returning to what we would consider higher risk, higher impact activities that are going to create more wear and tear. And so then that can drop the process down.
What about total knee replacement?
Total knee is probably around 15, 20 years. I'm finding that knees tend to wear faster than hips, probably because of the mechanical nature of a hinge joint versus the ball and socket
So
joint.
shoulders don't have weight on them. What about the lifespan of a shoulder replacement?
Shoulder replacements probably actually were not even, the numbers are not as good on shoulder replacements, but that probably speaks to the development and the process where we're at with shoulders. You got to understand we've been doing knees and hip replacements for decades and decades, and shoulders are more of a new process. So if we looked at the older implants, probably put in 15 years ago, the survivorship was probably about 10 years on those. Now I think you have much more technology. You have much more in the mechanical side of it that is functioning better, and they're probably getting up to that 15, 20 years. And it probably has less to do with plastic wear as it has to do with other factors in that.
So it's the same thing now with the ankle replacement surgery that we're doing, and now elbow replacement.
Yeah,
we need to find out how
I
things
think
will unfold.
it's the evolution of the product. And if you look at ankles, ankle replacements probably had about a 2 to 5 year survivorship 10 to 15 years ago. They were not a long-lasting product. But now this new Star, some of the other products out there do have much more durability. And now we've got some even 10-year studies that they're still doing well.
Another time question is if hip degeneration is a wear and tear process, changing the bone, thickening it up, and breaking down the cartilage, how come there are 80-year-olds with wonderful hips and men and women in their 50s and 60s who are coming to see you for wear and tear? What's the difference?
Why would they possibly have great cartilage even if they're even runners, right? So I've even had 80-year-olds that said I've run every day of my life, but look at my knees, they look great. And I'm going to say the answer is probably for them genetic. There's a strong genetic component to cartilage quality, the durability of cartilage, the ability for cartilage to maintain its water content and its flexibility and its durability. And so some patients have a much better quality to that cartilage. If you look at it from a lineage standpoint, you can follow it down the family lines of my mom had bad arthritis, my grandma had her knees replaced when she was in her 50s, and you just follow this down the line. So that's why there's really no one factor that creates arthritis, a degenerative osteoarthritis. There are a multitude of factors that create it.
Well, here's a 79-year-old young man who wants to know how to minimize future hip degeneration.
So
Any questions? Should I eat something different? Should I exercise differently?
right. So the answer is absolutely there are things you can do. I think there are things that you can do to protect any of your joints. The most common and probably the best answer that I have is maintaining muscle strength and flexibility of the joint. So muscle strength will be the one thing that will always save a joint. It is what allows us to distract pressure, right? So a weight-bearing joint is distracting pressure when we have better muscle strength. We're balancing and we're allowing that joint to reduce the amount of stress placed on it. Second is going to be flexibility. Flexibility from the simple point that we're going to have more contact in different areas of that joint when we're more flexible. If we lose our flexibility, there's going to only be certain contact points that continue to hit together, and we're going to continue to wear those areas down quicker.
So the emphasis on aerobic conditioning as we get older, you're adding strength and flexibility.
I'll tell you, I think aerobic exercise is wonderful for your heart. It's wonderful for your lungs. It's good for your overall endurance and your ability to continue being active. But muscle strength is the key to joint preservation.
Do you recommend flexibility with programs like Tai Chi or yoga, water workouts?
Yeah, so anything that produces flexibility. So yoga is going to be a great form. It's going to allow us to produce both strength, right? Because yoga is also a strengthening exercise, as well as a flexibility exercise. Anything that promotes that. So Tai Chi, anything that gets you active and mobile and flexible and keeps you moving is going to be good.
Questions on supplements, nutritional supplements, but especially turmeric, chondroitin sulfate, and glucosamine, and CBD.
Okay. So all nutritional supplements and additives that I hear about every day in the office. Turmeric, anti-inflammatory, basically a natural anti-inflammatory, and I think has a lot of validity to controlling the symptoms of joint inflammation and arthritis. And I think it's a very viable treatment. I think patients do well with turmeric, and I think it has a lot of validity. If you look at glucosamine, chondroitin sulfate, I have some ups and downs to it. The upside is I've actually never seen anybody take it and say it harmed them, right? So I've never seen anybody take that and have an adverse effect from it. I fail to see some of the biophysiology of how it's working and how it performs, but I have a lot of patients that tell me they take it and they feel better, right? And then I stop taking it and then I don't feel good. So if I know it's not going to harm you, and I know it doesn't have a lot of harmful effect, and you can take that and feel better and be more active, I'm all for it. I think it's a positive thing.
Question again on time is, you mentioned these younger patients where the ball of the femur is losing its blood supply and the ball deteriorates, aseptic necrosis. Why would we be seeing that in younger people with an increasing frequency?
Right. So avascular necrosis, and I don't have the exact numbers on the increase rate over the last 20 years, but we know that 90% of them are undiagnosable. We don't understand why they happen. We don't have a good common reason. We have some common ties to about 10% of them. We can see that chronic steroid use, so our patients that are rheumatology patients that have a lot of autoimmune issues that are on chronic steroids, they have a much higher propensity to developing avascular necrosis. And there's really certain areas where that occurs, but the femoral head is definitely the most common. Alcohol abuse. We have a link between alcoholism and development of avascular necrosis. And then we look at some of the collagen deposition diseases in childhood. But these are kids that we can see that. We know exactly why that's happening because those are things that are going to create congestion within that vascular system, and we see it early on with them. The majority of them, we have no understanding of why it happens, and there's no common rhyme or reason.
So if someone comes with the factors you've mentioned, limitation of activity, pain in the front of the leg, your approach will be clear diagnosis with whatever studies you may need, scanning and x-rays, and then you think it through, and then you present to the patient the options. That's the point at which you'll talk about your approach and what's going to happen afterwards.
Right.
Do you order physical therapy before every surgery to get patients ready for the rehab?
That's a great question. And the answer is no. No, because not every patient needs physical therapy before the surgery. But I have definitely taken that to heart probably in the last 5 years of physical therapy preoperatively and the benefit of it. So patients that have any kind of deconditioning, patients that just don't have the strength, we got to look at this from not just a lower extremity strength either. So I have a lot of patients that I will send to therapy to build up upper body strength. Because for about a week or two, they're going to be on a walker. And I can't tell you how many times patients have said, I just can't go on this walker. I can't get up and move on this walker because my shoulders are killing me now. Or my arms are tired. They're giving out. I can't support myself with this. So it's really about overall body physical improvement. So physical therapy is something that I encourage for anybody. And really in our joint center, in the St. Francis Joint Center, we have a whole class and we have a whole program set up. That does not include always formal therapy, but it includes preoperative therapy exercises. So those patients that are able to and ready and willing to do the therapy on their own and do the exercises, they have a routine set up for them and described and performed. Those that aren't as either motivated or capable of doing that are able to get into that physical therapy where we can do it in a formal setting.
So one of our audience texted in 3 years after knee replacement and still experiencing pain in that knee. what's your thought, your approach on patients after replacement who are still uncomfortable?
Right. So again, and it probably goes to, patient expectations. We have to be able to communicate clearly with patients about what the potential expectations are, what are they looking to achieve, and then what are the potentials for continued pain. Like I've said, in a hip setting, we say, look, I've replaced your hip, but your hip is not bionic, right? You still have a lot of your own original structures, and the same thing for the knee. So somebody that's about 3 years out from surgery, undergoing a knee replacement, the answer is, well, one, we can have other structural issues. Is it just inflammation of the synovium? Is it a capsular problem? Is it a ligament problem? Is there some soft tissue problem that continues to create pain? And so then you have to work through how much physical therapy did we do? What's our range of motion? Did we develop adhesions? Did we develop a complication afterwards? And then we can work through and really go through that laundry list of potential reasons why we still have pain. So there are diagnostic things that we can do to try to determine why. I would love to say that every single patient I've ever done a knee replacement on never had an ounce of pain afterwards, but it's not true. There are some patients that will either continue to have pain or they will develop pain later on, even after the replacement.
Question on weight. I've heard that every pound of excess weight that we carry around puts 3 pounds of excess force on hips and knees and ankles.
3 to 4.
3 to 4 pounds.
Right.
Which, if a 40-pound overweight state is putting hundreds of pounds of force on those joints.
It absolutely is. And again, that's why I will say that there have been more than one occasion that I've had a patient from a radiographic standpoint as well as a subjective and objective standpoint in the office on exam needs a knee replacement, but we work them through a weight loss program and I don't see them again. Or they come back and go, I don't think I need to do this yet.
So lots of approaches you can take to delay what might be an ultimate replacement surgery, maintain function, keep people active, help them help themselves. That's nice. A knee question for you. Cortisone injections in the knee, pretty common. Is there a danger? How often?
Every great medicine has its potential to create problems, unfortunately. And so I will put steroids, cortisones, kenalogs, whatever you want to call them. They're basically our corticosteroid injections. They have a significant benefit for patients in the setting of a short-term understanding, right? So if we look at the short term, they're going to be very beneficial. They're going to give an anti-inflammatory effect that can allow patients to remain active and do the activities that they need and want to do. The downside for steroids are going to be, again, that overuse, that using too much, using them too often, the frequency. We do start to deteriorate joints with those. Bone and joint deterioration does occur with chronic steroid use. So if we look in the particular instance of knees where cortisone injections are very common, there has to be a limit. There has to be a defined understanding of how much we should do and the frequency with which we should do them. My standard is 3 to 4 months in between shots within the same joint, and I will do, again, no more than 3 a year inside of a single joint. Used to, I would let patients do that for as long as we wanted, 2, 3, 4 years, because eventually you'll lose your effectiveness of them anyways. Nobody's going to come in 3 years later after getting shots every 3 months and tell me how wonderful it's still working for 3 months. It's going to lose its effectiveness. But now we really look at shifting them over to something that's got a little less potential adverse effect. The viscoelastic supplements, our Synvisc, Monovisc, our rooster combs, some people call them lubricants, those have a much better effect from a longevity standpoint and a much lower risk category for creating joint problems.
Well, speaking of injecting things, a question on stem cells, particularly in knees, but I'm hearing stem cells being injected all over the place. What do you think about knees and hips?
I think that we have to take caution as to how much and how often we're doing stem cells. You know, the one upside to stem cells was going to be the potential to eliminate the need for surgical intervention, you know, for having the patients have to go through surgeries. If we can regenerate cartilage, we can regenerate padding, then maybe we can eliminate that need for invasiveness surgically. And had it shown that potential and had it shown those numbers, it would be amazing, but I don't think it's really showing us that in the literature. We're seeing that there is definitely an anecdotal improvement. So there is a period of time where patients tend to feel better. But if we look at it from a radiographic, and there's even been some studies now done going in arthroscopically and evaluating these knees, we are not seeing a ton of actual cartilage development. Now, the other side of that is there is definitely some new technology that's being created for localizing where stem cells go. So being able to place stem cells in a specific area inside the joint may have more validity. I don't know that just randomly placing them in the joint is doing everything we want it to do. And if we look at, the only thing I will caution, I'm trying to say this as politically correct as possible, pay attention to who's giving you a stem cell injection. You need to be receiving that from a licensed physician. And it needs to be somebody that deals with bone and joint problems. Too many people I have seen that have had some questionable injections and things done because it is such a new and upcoming thing, and it's not an insurance-covered procedure, so people are going and paying out of pocket for these procedures, and I think there's some questionable validity to some of the places they're getting it. So research where you're doing it before you go do it.
So we have two last questions. One is you're dealing with a patient population in elderhood, 60s, 70s, 80s, and bone strength is going down in this age group. How do you deal with someone who has known osteoporosis, thin and brittle bones?
Yeah. So if you look at, sometimes that's even a potential contraindication to surgery for the risk of potential problems. In a patient that is severely osteoporotic, then we literally focus on trying to treat that problem before we address things surgically. So can we strengthen your bone up? Can we get you in, do our bone densities, and get our scaffolding built up, get our calcium levels built up, and really strengthen your bone? So if we need to do that, then we have to take that approach for some of the patients. The majority of it, though, is understanding it, right? So if you're talking from a surgical setting of how do I address somebody with osteoporotic bone, well, it's the awareness of it. I think the biggest complication comes from lack of awareness. If you're not paying attention, if you're not focused on the fact that that bone is weaker, you develop more of a problem. You don't know how to handle it or deal with it. So being able to see it, recognize it, and understand it is probably the key.
And your lovely pictures of the procedure and that table is very interesting.
Yeah.
But you're doing some carpentry in there. You've got drills and bits and rasps and pounders, and so if those bones are brittle, I can see the potential for changes and problems.
That's why my lecture slide will never be able to get rid of potential for fracture. I mean, it's an invasive procedure.
And our last question, and we thank our audience for their participation, is really not it's just a nice question about bones. When a bone breaks and it heals, there's a kind of a feeling that it heals stronger than before. Is that just a myth, or is that?
Okay, so the answer is yes, it can. All right, so there's two types of bone healing. There is the bone healing that creates a large callus or ball of bone around that fracture. And then there's fracture healing that occurs internally inside the bone. If we rigidly fix something and keep it together really well when it's broken, it will heal in that kind of internal structure. If we allow things to heal in a cast, if we break our wrist and we put it in a cast, we will heal by what's called callus formation. So when you develop a callus around that area of fracture, you're developing a significant ball of calcium deposit. And so you are strengthening that bone up. And yes, it is probably much stronger than it was before. But unfortunately, your body has a very specific way of dealing with bone strength, and it's the way your bones form, and it's why they look the way they do and why they function the way they do. And so it's able to resorb extra bone over time and really regain some of that original shape and position over time just by forces that we place on it.
Another wonder of how our bodies function. So I'm going to come up here to just stay right here. And just a thanks to Dr. Ryan Gursky for a sensational evening. Handled those questions well, very bright audience. Our next town hall is on July 15th, and we'll have Dr. Vijay Pandev, who is going to talk about strokes. And remember from our past town halls, we consider a stroke to be a brain attack. Like a heart attack, you want to act, you want to come to the hospital. We have things to offer. Strokes can be dealt with in important new ways. So we'll look forward to seeing you with your questions in just a few weeks. So good night all.